Good morning, everyone. It's my pleasure to welcome Grand Round speaker today, Dr. Ed McDonald, who is also our 2025 Dream Speaker, Residency Dream Speaker. So the Residency Dream Speakership was established in 2009 as a way for the residents to bring in somebody they feel is making a difference in both medical education and healthcare in general. Voted on by the residents, and today's nominee is Dr. Ed McDonald. So we're very pleased to have him here from the University of Chicago. Dr. Ed McDonald obtained his bachelor's degree in both biology and Spanish literature from the University of Michigan. He then went on to complete both medical school and residency at Northwestern University in Chicago, after which he obtained a fellowship in clinical nutrition from the University of Chicago while simultaneously attending culinary school at the Kendall School of Culinary Arts to become a certified culinary chef. He then went on to complete gastroenterology fellowship at Rush and later went on to finish a certificate in obesity medicine, and he's now the clinical director of adult nutrition at the University of Chicago and also runs a obesity medicine clinic, a nutrition clinic, a general GI clinic, and is there an IBD clinic in there, Dr. McDonald?
A little bit.
A little bit of IBD, okay. So outside of his clinical duties, Dr. McDonald has founded the Good Food is Good Medicine Project, which is a cohort-based kitchen learning class that supports up to 6 separate cohorts throughout the Chicago area and employs both chefs and healthcare professionals aimed to improve healthy meal choices through kitchen-based learning. And he's also become known for his work in diversity and equitability amongst GME programs as well as gastroenterology as a whole. He's the co-director of diversity, equity, and inclusion amongst GME programs at the University of Chicago and has published work in this space. And then he's also helped found the Bust in a Gut program through the AGA, which aims to increase comfortability surrounding digestive health disorders and pairs with local comedians. And he has had performances and participated in this panel as both a comedian and gastroenterologist in LA, Chicago, and Washington, DC. And I was going to conclude by telling you about the children's book that he wrote, but instead I'll tell you that I learned last night he ended up on an Instagram Live with Katy Perry discussing the merits of apple cider vinegar. So he's an advocate no matter what you ask him to do. So it's my great pleasure to introduce Dr. Ed McDonald today, and please give him a warm welcome.
So, Lucas, thank you so much for that excellent introduction. Like, I need you to record that so I can play it for my wife. And I need to send it to the chair of my department. Like, I think I should get paid more now. But I appreciate that. So there you go. All right. So a couple conflicts I want to bring up. I do some consulting for Takeda and also Ironwood Pharmaceuticals, but none of these, my topic today won't involve anything related to those conflicts. So the name of the talk, as Lucas mentioned, is Why Are You Eating Hot Dogs Every Day? And I'm going to give my personal journey in terms of what brought me to culinary school and led me to become a chef and a physician. And I'm going to talk about how I help patients navigate the food landscape. And I'll get into a little bit of research that we're doing with some of my cooking classes, okay? So my goals are very simple. Just want to define the food landscape, want to define food insecurity, and also discuss some principles for navigating the food environment that I find helpful on the south side of Chicago at my institution. All right. So, as many of you all are aware, I'm the chef. I went to culinary school, and I did this after I finished residency, not before. And I started doing cooking classes in the hospital, very low budget initially. I just started in some empty conference rooms. I don't think I really asked anybody. Like I just, bought some equipment, put up some signs in the hospital, and next thing you know, a lot of our seniors with Medicare were showing up to classes, and it became relatively popular. And from there, I started doing classes throughout the community. So, this is me at a church, me at a kitchen Salvation Army, and it was a very low budget operation in the sense that I had no budget. It was a no budget operation. So I was buying food and paying for everything out of pocket, and that had its limitations. But eventually, I was able to get some grant funding, also some philanthropic support, and I started a program with one of my friends from culinary school, Chef Janine Wise, and we started this program called Good Food is Good Medicine, which now we have cooking classes all throughout the Chicago area. Not just the churches and the little hospital conference room where I got my start. So I finally convinced our hospital to build our teaching kitchen, which is actively being built right now in our new cancer center, which I'll be heading up in 2027 when all this is done. But this picture right here is a reminder for me to kind of explain why it is I became a chef. I remember I was doing a class in a hospital, and there was a person who had small bowel bleeding, and they called me after the class to come to endoscopy to do a double balloon. So I literally have my chef jacket on, and I'm, ended up in an endoscopy lab. Now, obviously, I didn't do a procedure with my chef jacket on because that would be 100% nasty. Um, but it shows you how a doctor who's a trained chef sometimes has to wear multiple hats. And it also leads me to, explain to you all why I even did this in the first place. Because I mean, this picture is crazy. I have a chef jacket on. There's a fellow with me. This makes no sense. So most people ask, how did you get here? And I like to start off just by telling a little bit of my personal story. So fundamentally, I was raised with the love of cooking. And a lot of that love came from the wonderful matriarchs in my family. So this is a picture of all my grandparents who were at my graduation. And my grandmothers taught me the joy of cooking early on because my mother, when I was a child, she had some health issues, and sometimes she would be hospitalized for maybe months on end. And my father, as much as I love him, he's part of that generation of men that think the kitchen is a place that's off limits to anyone who has a Y chromosome. Um, and for him, I mean, he just would not cook at all. So this is the 1980s. Microwave dinners were starting to become popular. We were doing microwave dinners every single night, and my grandmothers were like, "This is unacceptable." So they both gave me cookbooks. One gave me The Joy of Cooking. Another grandparent gave me another cookbook, and at the age of like 9 or 10 or so, I just started cranking out recipes. And I'm 10 years old making dinner for the whole family. And for me, I don't know, there was something magical about being able to turn random ingredients that seemingly weren't connected into a whole meal. Um, and then the other really main reasons happen a little bit later. So, three reasons I like to share. I didn't realize that diet was connected to disease until I was a kid at church, actually. So, our church service, there was a moment in the service where the pastor always asked us to pray for people who are sick and shut in. Um, and oftentimes he would give reasons as to why people were sick and hospitalized. And a lot of these reasons were the chronic diseases that we're all familiar with: diabetes, stroke, high blood pressure, heart attacks. But you can imagine as a kid witnessing when people leave the hospital, it's very traumatic. You see an elder that you knew who they were talking beforehand, they had a stroke, they come back, then they're in a wheelchair and they can't move. Or you see someone who had both legs, they come back from the hospital and they're missing a leg. As a kid on the south side of Chicago, I was shocked by what I was seeing. And when I would ask my parents, I'm like, Dad, why did Miss Such and Such lose her leg? Like, what happened? I'm thinking, like, was she in a war? Like, what happened? And my dad, again, being the funny person that he is, he was just like, she ate too much cake, uh, which is totally inappropriate. But I took him literally. So there were many years I was scared to go to birthday parties because I didn't want to get the cake. Um, Fast forward, I started working at McDonald's as a teenager. It was my first job. I was proud to have that job. But I started noticing families coming in almost every single day, sometimes twice a day. And I thought that was odd. I'm like, my family, we don't really go to McDonald's every day. Why are you? I saw you this morning and I'm seeing you here for lunch. What is going on? So I actually started making food off menu at McDonald's. which is totally inappropriate, but I was 16 and they made me a manager. You should never make a 16-year-old a manager of anything, but they did. I was trustworthy. I didn't steal, but I made food that wasn't on the menu. That was my weakness. So I started making things like frittatas. I started making omelets. I mean, there's never been an omelet on McDonald's menu. Um, but people really enjoyed it. And I didn't realize the value of what I was doing until people came to McDonald's and they asked for the secret menu. And even more shocking, police officers would come in and ask for the secret menu. Now, I didn't think of how that could be valuable until I got pulled over by one of those police officers on my way to school. And they pulled me over. They asked me to get out the car. Next thing you know, on the loudspeaker, I hear like, "Are you that guy who works at McDonald's with the omelets?" And I'm like, "Yeah," and they just drove off. Uh, so that experience showed me that food is powerful, but it also showed me that a lot of people really rely on fast food. And I was puzzled by that. And that's something that puzzled me even throughout medical school and residency. And the final reason is really one of the first patients I had when I was a resident at Northwestern at the Jesse Brown VA hospital. And I'm going to use his story to explain how I got into nutrition, but also how you help patients navigate the food landscape. So he was a 59-year-old veteran. He was divorced, he was underemployed, he also couldn't cook, and he had diabetes, hypertension, fatty liver disease, and he had a mild stroke. Um, and I asked him one of the most powerful questions that I think you can ask any patient: what do you eat? So his response was basically hot dogs. And I asked him, what do you eat for breakfast? He's just hot dogs. I'm like, okay, what do you eat for lunch? And he's getting a little bit more agitated as I'm asking him the same question over and over again. He kind of blurts out hot dogs, but there's a little bit of aggression in his voice. And I had to ask him what he was doing for dinner. So I asked him, like, what are you doing for dinner? And he yells out hot dogs. He's grabbing his coat. He's about to walk out. Um, on the inside, I felt like this. I'm professional, so my face didn't like this, but I was shocked because he was eating hot dogs pretty much every single day, every single meal. And as a medical student, no one prepared me for what to do when someone's eating hot dogs every single day, every single meal. But common sense would say that's probably not a diet that's associated with longevity. And when I looked back through his medical record in CPRS, there was no notes from any dietitians. No doctor documented that they talked to him about their diet, and all I saw were, people increasing his blood pressure medications. So they got to the point where he was on clonidine, and when you see clonidine, you have some serious blood pressure issues. I think they were even contemplating putting him on minoxidil for blood pressure. So they were really exhausting a lot of the options that existed at that time. So he told me that he didn't have any money, and also there were no grocery stores in his neighborhood, and he couldn't cook. So again, as a medical student, I never learned, what do you do when someone has no money? What do you do when someone says there's no grocery stores in their neighborhoods? And definitely, what do you do when people can't cook? How do you address that? So I really had to get a glimpse into his world to really figure out how to address these issues that he mentioned. So, that said, how do you really help patients navigate the food landscape? And has anyone else come across issues like this, or am I the only one? If so, if you have come across some of these issues, then I think this lecture really is for you. So one of the approaches that I first thought was helpful, at the end of the day, we're talking about behavior change. And when you're dealing with behavior change, even from a research perspective, or even just from a clinical perspective, it is good to understand basic theoretical frameworks that guide behavior. And I think that is a good place to start when you're dealing with somebody who's eating hot dogs every single day. So one framework that I use, which is really adapted from the obesity medicine literature and also the addiction literature, is the 5 A's framework. So whenever I talk to people about weight or even about food and food insecurity, I like to ask if it's okay to even have this conversation, because a lot of people may feel stigmatized by having a conversation regarding food. I think nowadays it's very easy to judge someone if they're eating hot dogs every single day or whatever it is that they're eating. Um, and then if they do say it's okay, that's where I start to assess how food is impacting their life. I provide some advice, and then we agree on a plan, and then we also work together for assistance. Another framework that I like to think about is the health belief model, which looks at a variety of different factors that underlie human behavior. And the health belief model primarily focuses on belief. So whenever I see someone, it's good to understand what their motivations are, what their health goals are, and to make sure our goals are kind of aligned. And then you really want to appreciate, do they have a perception of their susceptibility to disease based upon whatever behavior they're engaging in. So for my patient, it would be hot dogs. The conversation we ended up having, like, well, do you think hot dogs are putting you at risk for heart disease or for disease X or for even, premature mortality? Um, I also, when you use the health belief model, you have to talk about the perception of benefits for whatever behavior. So do you think eating hot dogs has benefits? Or do you think it doesn't have benefits? And then you also have to look at, are there any perceived barriers to adopting a healthy diet? And so for me, whenever I see patients, I'm focusing on their motivations. I'm focusing on obstacles when it comes to achieving a healthy diet. And I also keep in mind the socio-ecological model. Okay, so this is a model that really connects behavior to the nutrition environment, to economic factors, to cultural factors, and also individual factors. And as a physician, I really have to help people I really guide them through the socio-ecological model, even though we may not necessarily have a lot of time in clinic. But within 15 minutes, if you start asking some pointed questions, you can get a lot of information to help help guide people down the path of healthy eating. Another resource that I like to use, especially on the south side of Chicago, is trauma-informed care. And these are all resources that I not only use for patients in terms of my approach, but also when we do our cooking classes, when we develop curriculum for our cooking classes, I embrace a lot of these concepts in almost every single thing that I do, both community work and also patient care. But trauma-informed care, there are really six main principles of trauma-informed care: establishing safety, establishing transparency and trustworthiness, and then using peer support, which is very helpful in the cooking classes. And also we have a group weight management clinic. So I like patients to kind of support each other. And then collaboration, for the most part, I really try to empower people, to encourage them that they can make some of these changes. And then you have to be very sensitive to cultural, historical, and gender issues. So fundamentally, I employ all these frameworks by using motivational interviewing. And this is a paper that I published not that long ago with our approach to incorporating motivational interviewing within cooking classes. I think this was the first paper where anyone ever documented how do you do that in a group setting, specifically in a cooking class. Um, Another principle that I like to emphasize whenever you're trying to change behavior or whenever you're addressing food insecurity or food access, it's good to know, like, why are you doing this? And as I said previously with trauma-informed care, you really want to establish trustworthiness. And knowing your why is really the foundation for not only trust, but authenticity and transparency. So obviously, we know that diet has a connection to disease. So in a study that was published in JAMA back in 2018, it really highlights the importance of diet when it comes to premature mortality. So they looked at 17 leading risk factors that were associated with early mortality. And of the 17 leading risk factors, including tobacco use, including having high blood pressure, including high BMI, diet it was the leading factor for early mortality, and most of those early deaths were due to cardiovascular disease. Um, in Chicago, there are stark health disparities. And for me, growing up in the city, I want to figure out whether or not diet is connected to some of the disparities that we see. So this is a study that demonstrates life expectancy based upon which neighborhood or which train line feeds your neighborhood. So on the north side, someone born in Lincoln Park has a life expectancy of 81 years. Someone born in Washington Park, which is just blocks from the University of Chicago, blocks from a notable academic institution, life expectancy is only 69 years. And this is our backyard. To me, that's insane. And if you go out to the west side, life expectancy is also a little bit lower on the green line at 72 years. Another study that was done by NYU found that someone born in Streeterville, downtown, where I trained as a resident, life expectancy is going to be 90 years. But just no more than 8 miles away on the south side in Inglewood, life expectancy is only 60 years. This 30-year gap is the largest lifespan gap within any city in America. Any city in America. That's not something we should be proud of. I mean, I can be proud of Michael Jordan, but we should be ashamed of this as Chicagoans. And I don't think this is a Democrat-Republican issue. Like this is a problem. This is a problem that it's a problem that also has a solution to some degree. And I want to talk about solutions, okay? So one of the reasons why I'm really concerned about food access and food security is really because our patient population is also concerned. So every 3 years, we do our community health needs assessment, and we ask our constituents within our 12 zip code service area, what are the most important community priorities, or what are the most important health issues in our neighborhood? And our respondents, most say mental health, some say violent crime. We're on the south side. And then others say access to healthy food. Okay, that's number 3. And that's number 3 on the list for most of our patients. Number 4 and 5, obesity and diabetes. Now, arguably, obesity and diabetes, these are also related to food. So within the top 5 issues, 3 have a clear direct connection to what people are eating. Another example I like to give, as a director of nutrition, I provide TPN. So oftentimes I'm in the burn unit where a lot of patients, including kids, need IV nutrition. And I come across a lot of people who have burns. And we did a study at the University of Chicago looking at the most common reason for scald burns amongst kids, because we would see a lot of kids coming in with burns from being scalded. I just want to throw it out to the audience. What do you all think is the most common reason for pediatric scald burn admissions on the south side of Chicago? Any ideas? Canned soup, okay, it's a good idea. Anybody else? It's ramen noodles. Ramen noodles. So about a third of our pediatric burns come from ramen noodles, and the median age for these burns, age 5, okay? And most of the kids who have the burns were unsupervised or even alone at the time of cooking, and 90% were African American. Now, you have to think about what circumstances would put a 5-year-old in a position where they're making noodles by themselves to the point where they're at risk for getting burned. And what ends up happening, typically, the scenario is they put the noodles in the microwave. The microwave is a little bit high up, or the kid may have to get a stand, and as they're trying to get the noodles out, the noodles spill, and they have a bad burn. For me, when I think about the reasons why an unsupervised 5-year-old child may be cooking instant noodles, it's not just that they like noodles. There's more to that story. And that story often includes social determinants such as poverty, food insecurity, lack of childcare, and the food landscape can also play a role. So instant noodles are all over the place in Chicago. You can go to any gas station and find instant noodles. You can go to any corner store and find instant noodles. I can't say the same about kale and apples and fresh fruits and vegetables, unfortunately. And instant noodles are also very cheap. So at most gas stations, you can get instant noodles for $0.25. Like you can't even get Snickers for $0.25. But the instant noodle packs by themselves are typically about 25 cents. And most people, even if you do have food insecurity, 25 cents is affordable to some degree. Another concept that I like to impress upon you all is using structural competency, okay? So instead of just assuming people are, doing ramen noodles because of a cultural reason, there's structural reasons as to why people are doing that. And structural competency, at least with the original definition by Metzel, it is an approach to clinical training and practice that aims to improve healthcare by directing attention to the social inequities that are among the root causes of health disparities. Um, when I look at this data with that structural competence in mind, I interpret it a different way. So this is from the Chicago Department of Public Health that looks at the percentages of people who are drinking sugary beverages daily. And there's a disparity based upon ethnicity in Chicago. So Hispanic, non-Hispanic, Black Chicagoans are drinking sugary beverages daily at a higher rate compared to other Chicagoans. And the same thing with fruits and vegetables. So when you look at who's eating at least 5 servings of fruits and vegetables combined in Chicago, there is there's a difference between Black and Hispanic Chicagoans. Not too much of a difference. I mean, I would say everybody's doing bad. Like this is not good for anyone. But certain groups are a little bit worse. And I think ultimately the goal is to prove this for everybody. Um, but on the South Side, I have to think about the demographics of the patient population that I serve. And when we do our community health and needs assessment, we uncover some of these demographics. So I know that 26% of our patient population is below the poverty line. About 15.8% has unemployment, 17.5% has food insecurity. So when I'm in my clinics and I'm discussing, putting people on the low FODMAP diet as a gastroenterologist, I have to be aware whether or not they can even afford the low FODMAP diet. When I'm in my weight management clinic and I'm seeing people eating ultra-processed foods multiple times a day, and I'm saying you need to eat more fruits and vegetables and whole foods, I have to be aware whether or not they have access and can afford those food items, primarily because I know that in my service area, there's a lot of people who cannot, and they may not tell me up front that they can't afford it. Another reason why it's good to be aware of how structural issues can impact behavior is because when you're thinking about ultra-processed foods, we know that food insecurity is associated with higher rates of ultra-processed food consumption based upon NHANE data. And we also know that ultra-processed foods are associated with increased mortality. So there was one study that actually found when people are consuming greater than 4 servings daily of ultra-processed foods, that was associated with a 62% increased risk of mortality. So when I look at some of the disparities in life expectancy in Chicago, like this has to be a part of the conversation. And if we just focus on violence and things of that nature, we're not really getting a full picture of what's going on. And as a result, I think doctors, really have an ethical obligation to really ask about food insecurity, especially in primary care settings. Now, the question is, how do you ask about food insecurity? For me, as a medical student, I was never taught, what food insecurity is, let alone how to ask about it. Am I alone in that? Did anyone else get taught about food insecurity as medical students? Maybe they've updated the curriculum in the years, I mean, at this point, the couple decades since I've been a medical student, but I don't think they have. So people have done research to figure out the best way to ask about food insecurity in a clinical setting. And what they found was written questionnaires may be more effective than verbally asking about food security. And for the finding really demonstrate that there may be still a stigma with food insecurity. And I don't think people are comfortable just saying like, yeah, I can't afford food, but they're more likely to actually say they can't afford it if they write it down. So this came from a study that looked at almost 8,000 well child visits, and they asked people verbally if they have food security, and they asked people via a written questionnaire. And they asked people both. So more people admitted to having food insecurity on the written questionnaire than when they were asked verbally. So this is something that we all should think about when we're screening our patients. Instead of just asking the question, we may have to write it down so they can fill it out. Now, how do you assess food security? Well, I like using the hunger vital sign, and this is something that we do in our cooking classes, especially in our research cohorts. Simple, only 2 questions. Those questions are, did you worry your food would run out? And did the food you bought last or run out? And these questions come from a study that was done by the USDA, where they looked at, they correlated the answers to these questions to people who had food security, low food insecurity, and very low food insecurity. And what they found was people who had low food security and very low food security had a higher likelihood of answering yes to these questions. So that is essentially where the hunger vital sign came from. Um, Another question that I like to ask my patients, but also people who come to our cooking classes. Every cooking class, we do an intake form, and we ask people where they get their groceries from, because that tells me a lot about people's food security status, what neighborhoods they're living in, and also the quality of food that they have access to. So there were some studies that have demonstrated that when people only shop at convenience stores, the risk of cardiovascular disease goes up. So I want to know if people are primarily going to convenience stores or you're going to grocery stores. Um, and there's a way to actually study or better qualify the quality of the grocery stores that your patients or participants in a research study are going to. So researchers at the University of Pennsylvania, they came up with this nutritional environment measure survey for stores. There's multiple different questions that if you're at the store, you can identify if they have fresh vegetables, and there's a bunch of different criteria, but at the end of doing the survey, you can come up with a score. So what we've been doing, we have our medical students actually go to the stores where our participants are coming from or shop at for our cooking classes, and the medical students will fill out the survey so we can have a better idea, a better understanding of the quality of stores that a lot of our participants in our cooking classes are using. Um, I think structurally, you also need to understand the food landscape. So, a lot of people with food insecurity may also live in low income, low access census tracts. And again, this is a concept that affects many Americans that I was not taught about as a medical student. So, I think in general, it's good for us as physicians to have a certain awareness of what the food landscape is. Um, the term food desert is very popular in America, but it did not originate in America. The term food desert actually came from Scotland. So in Scotland, in the 1990s, the public health department there, they were doing a study to figure out why people were dying early in what they called the tenements. Okay, so tenements essentially were their version of public housing. And they commissioned the study and found that in the tenements, there essentially was no grocery stores. So they came up with this term, food desert, to explain why everybody was getting cardiovascular disease and other chronic diseases in these tenements. And the term essentially, since the 1990s, became very popular. And in the United States, we have a more specific definition from the USDA, and that is a area, it's called a low access tract. We typically don't call it a food desert in the research literature. But the USDA definition of a low access census tract is an area where there's at least 500 people or 33% of the population that live more than, in an urban setting, 1 mile from the nearest supermarket, in a rural setting, 10 miles from the nearest supermarket. And I want to point out that I think in general, we make the mistake of thinking that food deserts are only an urban issue. And that's blatantly false. I mean, this affects a lot of Americans, including people who may live on a farm, including people who might be just, 10 miles away from Madison. Um, so I think it's really important to not fall victim to the fallacy that food deserts are just an urban issue. This is really an American issue to some degree. And I like to point out, the last time they did the study, in 2015, they found that about almost 40 million, or 12.8% of the population of the United States, live in quote unquote food deserts. This is a lot of people, okay? So this is a risk factor for chronic disease that affects 40 million people that we don't even learn about in medical school. And to me, that's sad, but it's also insane. In Chicago, most of the food deserts are almost exclusively in predominantly African American neighborhoods. Um, but again, I want to emphasize that this is not a South Side of Chicago issue. This could affect people, again, who live in farms. Um, Now, the impact of food deserts on health, controversial. It's controversial for a couple of different reasons. one of my colleagues at University of Chicago, John Pierre Dubé, who's a economist, he did a study where he looked at 60,000 households and he looked at purchasing habits as far as uh, what groceries were people were buying, and also where they were getting their groceries from. And with mathematical modeling, he found that even when you expose low-income households to the same food availability, to the same prices experienced by high-income households, that would only reduce nutritional inequality by 9%. Okay, the other remaining 91% difference is driven by differences in demand. Um, Now, there are people who took this study as a reason to not, provide food access, to not address food deserts. But I think they're missing the point. To me, it just means that behavior is more complicated than availability. And that's not a surprise. Like, we know that. If you go to, say you're a resident here and you're in ICU and they have donuts available, and next to the donuts they have apples, I guarantee you half the doctors and nurses are going for the donuts because even though the apples are available. So demand plays a role in everyone's lives. Um, Another study that showed that food deserts are a little more complicated than face value was a study that was done in Baltimore Public Housing. They were trying to see if people who had a car um, were eating differently than people who did not have a car. So the people who had cars, they could leave and go to, wherever they wanted to go to get their groceries. And what they found was there's really no significant difference in diet between those who had cars and those who didn't. So a lot of times, even though you had the ability to leave the neighborhood and get healthy food, you still just ate at the same convenience store that everybody else was going to. So I think there's other worrisome factors in the food environment that we need to focus on besides just classifying places as food deserts. And I give you one example. My patient who was eating hot dogs every day, he lived in the neighborhood Inglewood in the south side of Chicago, and that area is also a food swamp. So these are areas where large amounts of energy dense food almost overwhelm and inundate the healthy food options. I mean, there's food everywhere in places that we define as food deserts. So a lot of these places are not necessarily a food desert. They just have so much unhealthy foods. And this is something that I have to really help a lot of my patients navigate in my weight management clinic. So there's this concept of stimulus control. So stimulus control, again, a good example, you're in the ICU and they have donuts at the nursing station. You weren't thinking about donuts, but you see the donuts and now you're stimulated to eat. What do you do when your whole neighborhood is stimulating you to eat something unhealthy? So a lot of areas that are food swamps, you can't drive more than a couple blocks without going past several different restaurants that have hyper-palatable food. Um, in my patients, I'm talking to people and they're like, well, every time I drive by this place, I decide to go to drive-through. So I literally have to give people different routes to get home or to get to work so they're not overstimulated by the foods that they're seeing. I also want people to bear in mind that the food landscape is not naturally occurring. And it's one of the reasons some of these terms, food swamps, food deserts, are falling out of favor because they almost imply that these are natural phenomena as opposed to phenomena that are driven by political decision, driven by economics, driven by a lot of factors that we somewhat have some control over, as opposed to, the weather. Like, I don't have control whether or not the Sahara is a desert or not. But we may have some control whether or not there's a grocery store in a certain neighborhood. Um, and it's one of the reasons why some food justice activists prefer the term food apartheid as opposed to food deserts. Now, how do you help people navigate food insecurity? It's a good question. So here are some tools that we'll go through. So one, I like connecting people to food and nutrition programs. There's this application online in Illinois where you can really direct your patients to just apply for benefits. Two, I like identifying whether or not community partners can help, and also use community health workers and social workers. I like connecting patients to food pantries. So in Chicago, we have a website where you can just click on it and type in someone's address, and all the different food pantries will pop up. Feeding America is a national website where you can do the same thing, and all these links work. You also can start a food pantry. So our medical students founded a food pantry in 2010, and we have food throughout the hospital that we don't ask any questions. People can come just get food if they need it. We even created a toolkit for hospitals who want to start their own food pantry. And then there's online grocery stores that have programs that also can help out. So for the sake of disclosures, I blocked out Instacart, but Instacart Health is a great program. And you can create your own Instacart store and give your patients a link, and they can get some discounted prices, but they also can look at what foods you think are healthy and shop off of that. Then there's urban agriculture, and there's also food as medicine initiatives, which include produce prescription programs that are becoming a little bit more popular, and medically tailored meals. And a lot of hospitals are now jumping onto the food as medicine movement. Medically tailored meals are meals that you can prescribe based on upon someone's condition. And we're going to see more in the next couple of years as far as their availability. And then there's cooking classes. So with food as medicine, if we're not providing people nutritional knowledge and how to cook, you can give them all the groceries in the world. A lot of stuff is going to go to waste if they don't know what to do with it. So I think the cooking classes that we provide are a nice adjunct. Here's a couple of videos of some of my classes.
Nah, it ain't working. It working. Hold on.
All right, you got it.
Oh.
So that was the first time this group of guys ever had all vegetarian and here's just a sampling of some of the food that we made. A lot of healthy, diverse stuff. I think this collard greens made with miso, my own personal recipe.
Okay.
And in our cooking classes, we've actually
So,
started a program
Sarah,
where we're seeing how the classes change. the
today,
microbiome.
but there's one thing you're probably
So,
wondering, and that's
this is
why
Sarah.
we want your poop. So we're just gonna come right to the chase. We're gonna talk about.
So Sarah's one of our research assistants, and in the video, she was explaining to our participants why we're collecting stool for the classes. And I just want to share some preliminary data that we have. So our cooking classes, what we found when people go through our 6-week cohorts, you can detect changes within their gut microbiota and also the gut metabolome. And we find that certain metabolites change significantly. So sugar alcohols decrease, then certain amino acids are enriched. I've been working with some of my colleagues who do metabolomic research. They've established a normal reference range for what a normal metabolome should look like, and we're comparing our participants after our classes to this normal reference range. So what we found was, there are significant changes towards having a healthier gut metabolome when people complete our classes. These are metabolomic scores after our dietary intervention. So a high score indicates a less healthy gut metabolome, or a metabolome that's further away from the healthy reference range. So a lower score means you are closer to the reference range. And for our participants, significantly, all the scores go closer to the healthy reference range. And here's a good example of changes in specific metabolites compared to the healthy reference range. So we find that short-chain fatty acids, just as acetate and butyrate, improve and become closer to the healthy reference range after people complete our classes. And short-chain fatty acids typically are a marker of consumption of fruits and vegetables and foods that have fiber. And we also find that caffeic acid improves. Caffeic acid, or at least decreased caffeic acid, has been associated with metabolic liver disease. And indole-3 propionic acid also improves, and that's a marker that's associated with a decreased risk of inflammation. In patients with inflammatory bowel disease, we find derangements specifically in that metabolite. So my patient who didn't have any money and didn't have any grocery stores in his neighborhood when I first saw him as an intern, I asked him, what vegetables do you like to eat? Just something simple. And he said broccoli. So I gave him a recipe for how to roast broccoli. I just wrote it down on a paper towel in the VA clinic, and I see him like 6 months later. He's down like 30 pounds. He's had intermittent episodes of hypoglycemia. He says he gets dizzy whenever he stands up. And I'm worried that I missed cancer. I'm like, did I check this guy's PSA? When was the last time he had a colonoscopy? What is going on? Then I asked him what he's been eating. And he was just like, yeah, I stopped eating hot dogs. And now I pretty much just eat broccoli. And I was able to get him off some of his blood pressure medications. They had him on insulin. I was able to get him on metformin, and his blood sugar was well controlled. So for me, it just showed the power of food. And I know I spoke a lot, but I'm going to stop there. So, any questions?
Thanks, Dr. McDonald. Any questions from the group? Apparently, I'm taking Dr. Schnapp's job today. Don't tell her. Okay, yeah, thank you. Donuts in the back. There's also fruit cups, I think, unless those are taken.
Right. It's stimulus control.
We have a question from the online audience. Do you focus, iPhone number 2 asks, do you focus your nutrition advice on types of food on likely vitamin deficiencies, such as vitamin D in dark-skinned individuals, especially in the northern US?
Oh, yeah. So vitamin D, I mean, there's probably an epidemic of vitamin D deficiency in northern U.S. So I check vitamin D and I provide vitamin D supplements, but I don't necessarily tell people to do a lot of food that's fortified in vitamin D. I think fundamentally you're going to get more vitamin D if you get sun exposure. And for people who have darker skin, you're going to have to be in the sun a little bit longer. Like, yes, it's tough to get sun exposure when it's cold majority of the year. Ultimately, my approach to vitamin D is just checking the level and providing supplementation when people are relatively low. And also, the vitamin D literature is kind of controversial. So there was a study that was published in New England Journal of Medicine several years ago that looked at vitamin D binding protein and variations when it comes to ethnicity. So what they found was African Americans actually have less vitamin D binding protein. So the active form of vitamin D, even though the total levels are lower, there's less vitamin D that's bound to the vitamin D binding protein. So at a lower level, you actually may have as much functional vitamin D as somebody else who has more vitamin D binding protein, but more of it is actually bound to this vitamin D binding protein. So with that said, a person of color, specifically African American, their low vitamin D level may not necessarily be as bad as we once thought it was. That's an area that still probably requires further research, but it is something that I keep in mind because at the end of the day, you don't want to give people too much vitamin D where now their calcium levels start to go up and, calcium deposition in the blood vessels is probably not a good thing at the end of the day too. So I want people to be within the normal range, but I definitely don't try to overshoot it. So when I see patients who have like vitamin Ds of 80, I don't know if that's a good thing in the grand scheme of things, or if that's necessary.
One question I had was about advocacy from like health institutions or even physicians locally. What would be some of your advice in this like environment going about trying to change some of these policies or, trying to help our patients, not only like some of the resources you pointed out, but holistically as like the food landscape in America trying to fix it going forward?
Yeah. I mean, the way I've always approached things is just really telling the truth and looking at the literature and looking at evidence, but not only telling the truth for one particular community, looking at food problems within America as a whole. So when you look at West Virginia and people who live in rural America, like people are struggling and they're dying, from dying prematurely the same way people are dying in urban areas. And to me, like that is a problem. And I don't think you need to look at that as this DEI problem. This is an American problem. Like those lives matter too. And when I take that approach and have those conversations, especially with elected officials, that we have to focus on everybody, not one particular group, but everybody. The conversations become a little bit easier to understand. Um, so I've had the opportunity recently, as recent as February, to actually go to the Capitol and present to Congress. And I presented on why we should get government support for cooking classes and food as medicine. The funny thing, there was supposed to be a bunch of representatives there. None of the representatives showed up. They were in their budget meeting, so that's a good reason to skip my meeting. I get it, you got to pass the budget. But all their staffers were there, and subsequently I have a lot of follow-up meetings. So we'll see what comes from that.
Thanks so much. My question is, what do you think clinicians, especially like primary care clinicians, get wrong when doing counseling about nutrition for their patients in the clinic? Like, what are some pitfalls that people fall into?
A lot of pitfalls. I mean, it's another lecture. I think the biggest the biggest issue is the language that we use when we talk to patients about food. Food is a very personal subject. It's a very sensitive subject, and there's oftentimes backstories when it comes to food that you may not even be aware of. So I'm very cautious about describing someone's behavior in moralistic terms, like good or bad, because if someone tells me that, they love a sugar cookie, I'm not going to say that the sugar cookie is bad, because ultimately that sugar cookie may be their grandmother's recipe or something like that. Now, I will talk to them about the frequency of eating sugar cookies, and how if you're doing the sugar cookies multiple times a day, that is putting you at risk for exposing yourself to excess calories, which also carries a risk of weight gain. And in the sugar cookie in particular, you may be increasing your blood sugars or something along those lines. So I like to provide a narrative that is kind of rooted in outcomes as opposed to moralistic judgments. And I think a lot of patients that I've seen, especially I've seen other physicians, they'll come to me and say, well, Dr. Such and such said this is bad. I mean, I think as physicians, we can do better than just saying good or bad. And the reality is, if you eat one cookie, like that's not, if the cookie's delicious, then it's good. But, if you're eating cookies every single day, multiple times a day, in addition to sugary beverages, in addition to chips, like that is a pattern of eating that I don't want to say is good or bad. It's a pattern of eating that's been associated with chronic disease. And it's not up to me to say whether or not that's bad. It's really up to the patient to determine for themselves if that's bad.
They don't digest as well. So the whole ability for people to transition the full plate, diet, they would have to refer to the plate and stuff. Vegetables and starch, vegetables and fiber. I can start to come with cats. It's hard for me to figure out how to help them sustain in their family structures and their parties and their culture they grew up in. So what are your thoughts about how to help that journey?
Yeah. I think this is why culinary medicine classes have value, because it's hard to just have that conversation in a 15-minute visit or a 20-minute visit, however long we have. When it comes to food, there is a experiential component with eating. It's not just enough to provide some education. People also have to experience. So I see a lot of patients who, have this concern about texture or have this concern about certain flavors. And a lot of those concerns typically are rooted in childhood. So people were exposed to something in childhood, they didn't like it, and they almost have PTSD, where like I had some mushy lima beans, I'm never gonna eat anything mushy, and you're like 35 years old. I mean, I'm being serious. This is all real experiences. In the 80s, it was rough with the lima beans, like the frozen lima beans from the 80s. Ugh, terrible. Um, but when you expose people to, different ways to cook, and now as an adult, they can consume some of the stuff in a way that's flavorful, you can blow someone's mind. For instance, I've seen a lot of people who like hate Brussels sprouts, and we do a class on where we roast Brussels sprouts, and oh my God, they're like, this is my favorite vegetable now. But as a kid, their parents were just boiling Brussels sprouts. Um, so I think providing the experience where people can try new things safely can have a huge impact on behavior. Because I think some people have just convinced themselves they don't like something, but that convincing happened during childhood, and it just kind of stuck with them.
Hi, thank you for your presentation. Actually, when you mentioned learning about chronic disease at church, kind of ring a bell for me because I also grew up in a community where most of the things that I will learn will come from like church service on Sunday. And from watching the videos, I saw that the cooking class mostly involved like young adult. And I was wondering if maybe your team has ever thought about having classes specifically for church leaders, community leaders, so that they can learn and also go back to their community and kind of trickle down the effects of your cooking classes.
Yeah, it's a good question. So our cooking classes, those are just 2 videos from like one random class. We've probably done, hundreds, if not 1,000 classes at this point. So the way I started the cooking classes, I started off by doing focus groups with community organizations, specifically the leaders of community organizations. And a lot of these are older adults, and they also included some of the religious organizations. And we brought them on as the first cohorts for our cooking classes. So they helped us shape our curriculum. They provided some feedback as far as recipes. But most importantly, they connected us with their respective organizations, and that allowed us to, really kind of spread our reputation and also let people know that we have these classes that are available. And the classes are free, by the way. So that is something that we already do, but I agree with you. It's important to really meet multiple generations when it comes to cooking. And I like showing that video because in that video, it was all young men. And I think there's a bias and or stereotype that a lot of young men are not interested in cooking. And that's just blatantly not true. A lot of them want to be in a position where they can cook for themselves because they realize that they have no other choice, fundamentally. And then plus cooking for yourself is actually cheaper than eating out all the time. So a lot of people who are 18 to 20 who are now leaving the house or maybe in college, maybe not, they're maybe not in college. They're just trying to figure out how to survive in a way that's cost effective. And I think cooking is a strategy to do that.
More questions online, Dr. McDonald. Have you found any amelioration in IBS from your dietary interventions?
A good question. We have not, so in my clinics, yes. In my cooking classes, I have not specifically had an IBS GI cohort, but we are working with the Crohn's and Colitis Foundation to do some cooking classes specifically with people who have inflammatory bowel disease. And when we have our teaching kitchen, one of my goals is to do one of my clinics within the kitchen where a lot of my patients who have IBS or who have GI diseases that would benefit from dietary intervention, they can just come to the kitchen with me and a dietitian, and we can talk about that in the kitchen. And I can still get paid as a clinic visit. So shameless plug, you can do group visits and bill a level 3 for like multiple people. So I started doing that with my weight management clinic, and I'll bring in like, 20 people or so to a conference room, and we go over PowerPoint about healthy eating, et cetera. And I can bill for 20 people, and that might be an hour's worth of work. And I still have the rest of my day to see patients. So there's ways to do this and still keep the hospital happy, because ultimately, I don't want the hospital coming for me as far as RVUs, which they will. But I say, well, these 20 people, their insurance are paying for this, so they kind of leave me alone.
Several questions about the practicalities of your cooking classes, like how long do they last? How do people enroll in Chicago? Like how
Yeah.
exactly does that work in practice in the Chicago area?
Yeah, so the classes typically are about 2 hours. We spend, maybe about an hour and a half cooking and then 30 minutes of a nutrition lecture. And each class, we have different topics, different recipes, different techniques for each class. Um, we do them in multiple different places. One example, so the videos I showed were at the hatchery in Garfield Park. That is kind of a ghost kitchen that you can rent out. And Rick Bayless, the celebrity chef, actually paid for our kitchen. So Rick has a program at that same kitchen that called Impact Culinary. It's almost like a culinary school for people who don't have enough money to go to culinary school. So they get an expedited culinary experience. And I was one of the people providing the nutrition education for that school. And Rick Bayless was nice enough to give us access to that kitchen. And we started, that's really our flagship for our cooking classes. And in other places, I mean, we're using the basement of churches, the Salvation Army, we can use their kitchen for free, as long as people who go to the Salvation Army also have access to our cooking classes. So we use and rely on a lot of community organizations and community partners in order to make this happen and keep it free. I do have some grant funding, but we also have some philanthropic support. So Blue Cross Blue Shield support, it's one of the insurance companies in Illinois. They support some of our efforts. Lucas Walton, who's part of the Walmart family, got wind of what we're doing, and Walmart is a supporter. And then we have the Gastrointestinal Research Foundation, which is part of the University of Chicago, and we have our separate grants that we can apply for as faculty. So I have some research dollars through that. But I think fundamentally there's a lot of opportunity. There's a lot of people who are willing to support access to healthy food because I think most Americans know that this is a problem, and they want to see hospitals be part of the solution. So anytime you're coming up with creative ideas and you can actually demonstrate that your idea has an impact, people tend to be willing to fund. NIH funding is a little funny nowadays, but this is another conversation.
Thank you so much. This has been amazing, and seeing the work that you've done, holy cow, this has been a lot, and it's overwhelming to think about starting something, but gosh, you've given us great examples. You're really inspiring. My question, since you've done so much work, can you let us know anything about the tricks of insurance that maybe you haven't mentioned yet? Are there things that we can prescribe that may be a little bit easier to get some of this started, and things that patients already have access to that we aren't utilizing?
Yeah, it's a good question. So some insurance companies will cover medical nutrition therapy. So you can use medical nutrition therapy as a billing code and get that covered. Medicaid coverage is going to be state to state dependent, but there are more states where Medicaid is actually covering these cooking classes. For me, when I do my group visits, as a gastroenterologist, I mean, there's a lot of different codes that I could put in there to get covered. But if you're going to do it in a weight management context, like it's pretty easy to get like, obesity education covered. So I found it easy to specifically just put obesity for the patients that I'm seeing. For everyone else, it really just depends on insurance to some degree. But this is one of the reasons why I think more advocacy is necessary. So coming here to Madison, seeing the beautiful Capitol building that you have, I mean, the state capitol is like right across the street. So this is probably one of the best places in the country for physicians to engage in advocacy, to get connected to the policymakers. So I would take advantage of being located, really to the center of policy in Wisconsin. And you probably have a captive audience, and it's pretty easy to actually get meetings with some of these elected officials. Like they actually want to talk to people. So if you come with good ideas, you'd be surprised how willing they are to support. I'll give you an example. So Robin Kelly, who's running representatives in Illinois, she just issued a bill to support food as medicine back in November, and she used our cooking classes as one example of the things that should be supported. When I started classes in an empty conference room in a hospital, I had no idea that years from now, one of our elected officials would use this as an example within a bill that's like a real bill. But ideally, you just have to start somewhere. Now, I don't recommend that you just do classes without talking to anybody. There's probably, some rules that you need, some medical legal things you need to address. I was already a certified food handler, so I mean, from a public health perspective, I had the qualifications to handle food. But even still, doing classes within a hospital where you're providing food to patients for them to eat, you need to have a conversation with some of the legal folks just to make sure everything is covered from an insurance perspective.
Well, Dr. McDonald.
Liability
Oh, sorry.
perspective.
Thank you so much. This has been great. It's a little over past time, so we'll adjourn the questions there. But thank you so much for being our grand round speaker today.
Thank you.
We have this little plaque to award you with for being here. So thank you so much, and thank you everybody online and in person for attending.
Thanks so much.